Okay, so acute kidney injury used to be known as acute renal failure, okay? I don't know why they changed it, to be totally honest with you, but they did change it. So what it is it's actually a very rapid decline in renal function, all right? It can be over hours or it can be a few days, all right? The most common cause of acute kidney injury is ischemia, right? So that's perfusion, correct? So perfusion issues and also things that are nephrotoxic to the kidneys. So perfusion and nephrotoxins, okay? And the kidneys are very vulnerable to acute kidney injury because of the volume of blood that passes through them. So everything you put in comes out via the kidney, okay? And that's why they're so vulnerable to injury, okay? So anyway, acute kidney injury, especially if you're in the intensive care unit, has a very high mortality rate. So it's very important that you do an excellent assessment on your patient. Now, this is usually reversible, but the key that makes it not reversible is prolonged hypotension or prolonged hypotension or prolonged hypovolemia. And why is that? Prolonged hypotension or prolonged hypovolemia. What's happening, regardless of which one it is? Ischemia, decreased perfusion, okay? Hypotension or hypovolemia. So it's potentially reversible, and this is what usually causes it. Prolonged hypotension or prolonged hypovolemia, okay? Because I am not getting perfused. When the kidneys don't get perfused, they go to sleep, right? I don't need to do anything. I'm not getting any volume. The body doesn't need me. I'm going to go to sleep. Well, kidneys are critical, aren't they? Because you've taken care of renal failure patients, and they're very sick. You know, they're very, very sick. So anyway, what's going to happen then is you're going to get an increase, right, in your labs. One of them is your creatinine, correct? The only disease process that the creatinine is elevated in is kidney. Okay? Now, I'm not talking muscle builders. That's not a disease. The only disease process that you will see an elevated serum creatinine is renal. So when you see that elevated serum creatinine, you're going to have to say renal, 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 okay? The other thing that happens in acute renal failure, one of the things they start to have is a decreased urine output, okay? So they start having a decreased urine output. Now, depending on where they're at in this process, they can have a lot of potentially life-threatening problems, right? They can have really severe metabolic acidosis. They can have a lot of problems with fluid retention, a lot of problems with electrolytes. I don't worry so much about my vitamin D right now, do I? I mean, that's a problem in chronic renal failure more, correct? Because then you get that osteodystrophy and things like that you usually don't see in acute renal failure because it's not long enough. So acute renal failure, right, is like from the start to 6 months. Anything over 6 months, they start to call chronic renal failure. Okay, I should say chronic kidney injury. See, I still got renal failure on the brain. Okay, so I worry more about removing the waste products, fluid and electrolyte imbalance, right? These are probably some of the critical ones right here. Erythropoietin is an issue too. But that's a lot easier to correct sometimes than some of the other issues that we have. Because when you have your renal patients, how often do they usually go to dialysis on an average? 3 times a week. Okay, so your patient went to dialysis yesterday. Today you look at their labs. Creatinine's 6.8, BUN's 100. What are you going to do? Who cares? They're going to dialysis tomorrow. What are they going to do? But yeah, you should see what it was yesterday, but they're chronic renal failure. That's an expectation, right? And as long as the patient's not symptomatic from the standpoint of life-threatening issues, are they going to do anything about it? Absolutely not, because the only thing we can really do for them at that point is dialysis, right? So it's an expectation that those are going to be elevated, okay? So that is an expectation, all right? So anyway, as I said, it can develop over hours or it can develop over days. And of course, it's very important for you as a nurse to watch any patient that comes into the hospital, okay? Because how many patients have cardiac tests done where they give them a dye? How many patients have all this contrast dye? Contrast dye is not good. That's why when these patients come back, or you even have a test done, a healthy person, and you go have a CT with contrast, you better start drinking some water when you're done, because you need to flush that out, because that is one of the nephrotoxic substances that can cause acute kidney injury, okay? Now, unfortunately, sometimes they won't use the dye because of what else is going on with the patient, but you also have to think about how much volume can this patient drink, because if they have comorbidities that drinking a lot of volume can impact their current conditions, you're going to have to be very careful, okay? Pardon me?
Would you give them a mucomist to help?
You could give them mucomist. Yeah, sure. You could give them mucomist to help, and they do that. They actually do that. Have you ever tasted that?
I've smelled it.
How many have tasted or smelled mucomist? Awful. Okay? I never give it by itself. I always mix it with something because it is so nasty. Okay? It is really, really bad. All right? You have a question?
Yeah, so in a chronic renal failure patient that you know is going to dialysis tomorrow, you don't try to correct your creatinine and all that. What if their potassium was very elevated?
Depends what very elevated is.
We'll say it's like 7.8 or 9 or whatever, but they are going tomorrow for dialysis, but they're having cardiac issues today.
Then you have to do something about it. Again, symptomatic versus asymptomatic. Okay?
Put them on telly and-
Hence, always have to have them on telly. Always. And this is the thing that I tell you. You walk by that desk all the time and those monitors are there. Every time you walk by that desk, or if those monitors are in the hallway and you have a patient on telly, you better be looking at it, because that can change just like that. You got to kind of integrate that as part of something that you do. Absolutely. If you start seeing some EKG changes, because a peaked T wave is very common with hyperkalemia. That's one of the things that you're going to see is a peaked T wave on the EKG. And so that's why you really want to start watching them, all right? Because they can cardiac arrest on you. They can cardiac arrest on you. So yes, if they're symptomatic, yes, I do, definitely. And a lot of patients, here's the key. With chronic renal failure patients, they sort of get used to having everything out of whack, okay? So they adjust over time. That, I've seen 6.9, 7.5s. Patient did fine, went to dialysis the next day, all right? But I've also seen those same kind of patients where I've had to call and have something done, okay? So it just depends. That's why it's critical for you to know your patient and to assess your patients, all right? That's absolutely critical, all right? Some definitions related to acute kidney injury that you should have already kind of had before is azotemia. And all that means is all these waste products are building up in the body. Okay, that's all it means. Waste products are being built up in the body. Uremia is basically azotemia with symptoms. So uremia means I have all these waste products in my body, but now I'm symptomatic. All right, that's the only difference. So you will see and hear these terms used. Okay. So azotemia, too many waste products. Uremia, too many waste products, but now they're making me sick. Does that make sense? So now it's making me sick. Then, of course, you know what oliguria and anuria means, right? Okay. Now, chronic renal failure patients can still have some urine output and some don't, right? Just depends on the patient. But oliguria is urine output less than 400 mLs in a 24-hour period of time. Okay, anuria, right, is I know the books say no urine output, but actually it is urine output of less than 100 in a 24-hour period of time. Okay. Risk factors, tons of risk factors. Diabetes, right? Diabetes and hypertension are the most common causes for acute kidney injury. okay? Now, why do you think that is? Why would diabetes predispose somebody to acute kidney injury? What happens to the body with diabetes? What's going on in your body?
Vessels are destruction of vessels.
Yeah, your blood vessels, right? What happens to your blood vessels? You have damage to the big blood vessels and the little blood vessels. Well, doesn't the kidneys have big and little blood vessels, right? Over time, you get damage to that kidney and then the kidneys can't work like they're supposed to work, okay? What does hypertension do? Same thing, increased pressure over time. So when you think about hypertension, we always think about the heart. And we're taking these blood pressure medications so that the heart this and that. But what about my poor little beans in the back of my back, right? God, they get tired of having that high pressure too. So you have to think about, right? We talk about how it controls blood pressure, but if they don't work, what happens? Blood pressure goes up. So my little beans get tired too from all that increased pressure over time in those kidneys. Those are the two most common. Now age, I hate talking about age at my age because everything falls apart. And I had it I looked up something on how much nephron, I think every year after 65, I'm not there yet. Thank you. Close, but not there yet. Or 70, oh, here it is. Every year this is evidence-based practices, every year after 65 or 70, you lose 3% of your functioning nephrons. Okay, hence why you see more renal issues in older patients. Okay, that's just normal wear and tear, just like your brain. Everybody, you see this thing and it says, oh, chronic, ischemic, whatever. Well, and brain atrophy. Welcome to old age. Okay, that's what happens. Your brain shrinks, your neurons don't work as well, and you don't have good blood flow. So that's a normal finding on a CT. Okay, family history, obviously. And again, the evidence-based practice shows that these nationalities, please don't memorize them, tend to have a greater chance for kidney injury and tobacco use. What about tobacco use? All right, vasoconstriction, okay? Vasoconstriction is huge with tobacco use, okay? All right, these are risk factors if you already have some kind of coexisting renal problem. Okay, like glomerulonephritis or Goodpasture syndrome, which is an autoimmune problem, then you have, those are risk factors. Anemia, why is that a risk factor for acute kidney injury? Everything relates to one word, the big P, perfusion. Been telling you that for the last 4 weeks. Perfusion, 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 right? I don't have oxygen on my red blood cell, right? Kidneys don't get it, okay? So chronic anemia, atherosclerosis, athero is what? What's the difference between athero and arterio? No. Okay, one is hardening. You got it. One is hardening, arteriosclerosis is hardening of the arteries, which happens with age, hence people get hypertension. Atherosclerosis is plaque buildup, okay? So with old age, you get both of them, all right? So that impacts your renal function also, okay? High protein diets, what do those do? It taxes your kidneys. Your kidneys got to work harder to take care of all that protein. So all these high protein diets that people are on really aren't good for them long term, okay? And obviously they're no good because it doesn't teach them lifelong, whatever. So the kidney gets taxed. Proteins are big molecules. And so the kidney has to try to filter these big molecules, and it has to work harder and harder and harder and harder. And over time, it just gets tired and wears out. Doesn't work as well. Hyperlipidemia, again, is related to the elevated lipids, which are fats that build up in the bloodstream and block arteries and blood vessels, right? So hyperlipidemia and allergies to nephrotoxic drugs. Now, NSAIDs are really bad and contrast dyes are really bad. NSAIDs are pretty much one of the most common causes of intrarenal renal failure is too many NSAIDs, okay? Too many NSAIDs can cause intrarenal renal failure, and we've already talked about the dyes, okay? Now there's drugs. Look at these drugs that can cause renal issues, okay? Aminoglycosides, such as gentamicin, is the most common nephrotoxin from an antibiotic standpoint, okay? So aminoglycosides are bad. So the reason I'm telling you this is if you have a patient come in and they're on gentamicin, garamycin, or any aminoglycoside, and they have renal issues, you better not give it. That's when you need to say, hey, 1-800-doctor, you know, this patient's BUN is this, their creatinine is this, you have them on this medication 3 times a day, okay? What would you like me to do? Okay, because otherwise what's going to happen, you're going to put your patient into renal failure. So see what I'm saying? You know, this is critical what you guys are going to step out there and do in 10 days, 8 days, 6 days, or wherever you're at. I cannot stress the criticality of what you are going to do, which is why I know I do what I do in clinical, because you're going to be taking care of people, and we're not an assembly line. You have to think about the whole patient picture and what's going on, okay? The comorbidities and how it affects what's going on with your body, the medications, and do I give this, don't I give this? You know, would I not? Why not? How is it going to impact my patient? You have to think about all those things, okay? So you can't just say, I'm going to give these meds. You got to say, oh, you know what? Their urine output was only 324 hours. They don't have that diagnosis of acute kidney injury yet, but their urine output is really low. Maybe I shouldn't be giving this medication, okay? Or a patient with liver failure, okay? I had that exact thing happen to a patient I took care of. Patient had liver failure and they were on Plavix. I'm like, why are they on Plavix? So the doctor came in and I said, I did not give this medication. This medication has been given, da-da-da-da-da. The doctor put in big letters when we had the paper, no Plavix. Please contact supervisor. Now, why was I the only one to catch it? People not paying attention. Now, we put that patient at huge risk, didn't we, for bleeding? And we already know that the liver's not manufacturing clotting factors. Do you see what I'm saying? I put together patho, and I know I harp on you about patho. If you know patho, you could answer this last test. It's all patho, isn't it? Okay? Everything starts with how is this kidney different than a normal kidney? What is happening? Why is it happening? Okay? So you have to think about the disease process your patient has and the pathophysiology and say, should I be doing this or should I not be doing this? You ask if you don't know, right? Use your resources. Penicillins, NSAIDs, Lasix. Hello? What do we use for all the time? Lasix, right? Sulfonamides are things like Septra or Bactrim. Okay, we see those a lot. Your cephalosporins are like antibiotics, like, I don't know, you don't see them as often, but like Ancef and Kefzol, those kinds of things. Anesthesia makes sense, right? Because that has to be excreted via the kidney, and chemotherapy drugs, right? Because, you know, in general, I just say chemotherapy drugs are nephrotoxic, all right? Nephrotoxic, okay? So acute versus chronic, I am not getting into the chronic part. You've already had chronic. But I will tell you that the literature says that up to 10% of patients that are in the hospital will get acute renal failure, all right? And that's kind of sad. The incident jumps to over 30 to 40% when they're in the critical care units. All right. So look out to my critical care person there. So it jumps up a lot higher if they're in critical care units. And the mortality rate is 60 to 70% in the critical care units with patients that end up with acute kidney injury. And why do you think that is? You got it. Who said that? Exactly. Say it loud. All the comorbidities and everything else that's going on in there. The majority of patients that are in the critical care unit have perfusion problems, either related to acute respiratory failure, ARDS, sepsis, cardiogenic issues, all relates to perfusion, okay? And so they have all these other things going on, and then they put them on vasopressors, right? Vasopressors squeeze a little bit to try to, you know, get that blood pressure up and get that volume going. But when I squeeze a little bit, I sometimes don't perfuse as well as I should. Hence, I got to make sure they're not turning blue, right? Okay. So, sorry, I got an ice cube. I didn't mean to do that. It just came out. I got to chew it. Sorry about that. Okay. So one of the most important things to remember about acute kidney injury, and bear with me if I say renal failure, because after 40 years, I'm so used to renal failure, is that it can come on very suddenly, which is why you need to always assess your patient. I don't care if they're a walkie-talkie patient, you always need to assess your patients, okay? When you're telling me they're voiding, I want to know, how do you know that? Okay, how do you know that? So you can't just say, yeah, they're voiding fine and not a problem. And if we treat it right away and we treat it aggressively, we can turn it around, okay? So that's why it's critical for you guys to make sure that you're always astute in what you're doing. Where chronic usually comes on insidiously or slowly, okay? So chronic comes on more slowly than acute renal failure, and chronic is fatal without renal replacement therapy. So what I mean by renal replacement therapy, what does your book call renal replacement therapy? Your dialysis, your peritoneal dialysis, and there's different types of that, right? Or your regular dialysis, okay? All right, so I'm going to talk about this, and then we will, let's look at this. We got the functions of the kidney down, Pat, right? You guys have all that. All right, so I'm going to talk on this slide, and then we will go to your little scenario that you did here. All right, causes of renal failure, okay? You have pre-renal, intrarenal, and post-renal. Pre means before the kidney, okay? So if you have a kidney, all right, I'll never draw another one like that, but just take a picture of that one. Then you know what my kidney, see, I told you, this guy's sick, okay? So pre-renal is up here. Pre-renal is before the kidney, all right? Pre-renal is before the kidney, all right? That's what pre-renal is, before the kidney, okay? Thought I had a cute little drawing. Intrarenal, okay, is within the kidney itself, okay? So I made that too big, but you have your kidney. We'll just make it smaller. Okay, so you have your kidney, and then, you know, you have your bladder, right? You have your ureters here from the kidney. I can't draw it all down here. Then you have your urethra, okay? So this is your bladder. Sorry. This is your urethra, okay? So this is post-renal. Post-renal is after the kidney, with one exception. Your renal calculi. They consider those whether the calculi is in the kidney, in the ureter. The ureter and bladder is definitely post-renal, right? It's past the kidney. But you'll see things in, I've looked in some of the NCLEX books, and they consider, when you see here renal calculi, that is still post-renal, okay? So when you're talking about pre-renal renal failure, it interferes with renal perfusion, okay? It interferes with perfusion to the kidney, and it is caused by factors external to the kidney. So not within the kidney itself. It's caused by factors that are external to the kidney, all right? So when you look at this gentleman, 46-year-old, what type did you give him? Pre-renal. Why did he get pre-renal? Okay, blood loss and shock, right? Blood loss and shock. That's pre-renal, correct? That's not within the kidney itself. That's not post-renal. So he underwent surgery for lacerations, little urine output despite fluid administration. He gets acute renal failure. So he is pre-renal renal failure because the problem is volume loss, right? Volume loss. volume loss is pre-renal, okay? So that's why he is in the pre-renal stage. So any disorder that significantly reduces that vascular volume, okay, it will decrease what? Cardiac output, correct? Hence, my kidneys don't get the volume because they're kind of way down here, right? In little beans, so they get a last, really. So, so any disorder that decreases vascular volume and cardiac output can do this. Now, the other thing that can cause a problem is if I have a high SVR, right? Because if I have a high systemic vascular resistance, what's going to happen? What's happening to those blood vessels with a high SVR? It's afterload. It's after the pump. Right, but what's happening to my blood vessels? They're constricting. Hence, I don't get the what? Perfusion. All right, so it's, again, all about perfusion. It's just where the problem is. So things like that will lead to renal failure. What else could lead to renal failure? Just common things. What causes you to lose volume? Dehydration, okay? Dehydration, all right? So I think about dehydration. How do patients in a hospital get dehydrated? What kinds of things cause them to be dehydrated? Diarrhea, excellent. Diarrhea, right? What else? What causes you to get dehydrated if you have the flu? What are you doing? Vomiting, right? See what I'm saying? So when you look at pre-renal causes, it's not always this great big huge thing like hypovolemic shock, okay? There's other things that you have to think about. See how I'm getting you to, this is how you got to start thinking. Wow, they've been vomiting or NG suctioning, right? What's NG suctioning do? Takes out fluids, takes out not only fluids, but what else does it take out? Electrolytes. So we look at NG suctioning. Okay, that could be something that could cause you if you take out enough fluids for a long period of time. Now, we usually take care of these people, right? Because what do? We replace the volume. But you have to know to replace the volume. That's why it's important for you to keep track of, how much diarrhea they have. If I have patients that are really having loose watery stools, I make them use a hat. So I can actually measure the amount of volume they're losing in that stool. Okay? And I should do that. Because some people have a lot of loose liquid stools. I don't know how much that is if they go in the toilet. So how do I know how much volume they're losing, right? NG suctioning, what do you do every shift? You measure it, right? You measure it and you document it so that we know what's going on. Same with emesis. If they have an emesis, don't just say, okay, and put it in the toilet. You need to mark how much that volume was. And there's reasons we do that, okay? Because we want to prevent volume loss and dehydration because that can cause these people to have pre-renal failure. Does that make sense? We okay with that? All right. Some of the other things that you're going to find that do this that we're going to talk about in a little while is sepsis. Whoops. Sepsis. And what sepsis actually is it's the volume is still in your body in sepsis, okay? But sepsis is a vessel problem. So if this is your normal blood vessel and your blood vessel is full, okay? Your blood vessel is full. What sepsis is going to do, or I shouldn't say sepsis, what the toxins are going to do, because that's what sepsis is a systemic infection. It's going to cause this to get bigger, okay? It dilates those blood vessels. And so when it dilates those blood vessels, I now have a volume problem, do I not? Because what's the problem with that blood vessel? It's not full, okay? That's why sepsis can predispose somebody to acute kidney injury, okay? Because I'm not full. It's not full. So how do you think I fix this? I gotta squeeze it shut. What do we give them? Some pressers. Because what pressers are gonna do is it's gonna squeeze this shut, okay? It's gonna squeeze that shut, all right? But again, remember, you gotta be very careful with pressers, and we'll talk about those when we talk about shock. So shock anaphylaxis, okay? Anaphylaxis can lead to this too. So here you think somebody's going into anaphylactic shock because, you know, we gave them an antibiotic they were allergic to, correct? Now you understand with allergies, you don't get a reaction the first time because you don't have antibodies. It's subsequent exposures in which you will get a reaction. But anaphylaxis does this too. It does it out here. It bronchoconstricts here and causes vasodilation in the periphery, okay? So what's happening is your pressure is dropping so low, all right, because I don't have the volume and I have this great big blood vessel. So again, when you think about somebody in anaphylaxis, you better think about their kidneys, okay? See what I'm trying to get you to think about? It's patho. What's going on? Why is it happening? What do I need to be concerned about? Yeah, I need to be concerned about that they can't bleed and get their blood pressure up. But what else is affected? My cardiac output is affected. My kidneys are affected. Do you see what I'm saying? That's how you have to think as a nurse. That's how you have to think for 250 tests, okay? That's how you have to think. So it's not just looking at one little piece, okay, of the pie. So those are some of the things that can lead to pre-renal failure, okay? So what is renal failure then? What causes renal failure? Okay, where does it act? Where's the problem? Right here, okay? So when you're talking about renal failure, it's conditions that cause problems because they directly affect the kidney structure itself, okay? So these are things that are affecting the kidney itself. So, well, yeah, certain things. I don't think infection, but I think lupus comes to my mind right away. SLE comes to my mind when I think about this. I think about blood clots, right? Because you've got those great big, you know, renal arteries and veins. So I think about thrombosis or blood clots. What else? Toxins. NSAIDs are huge, is what I'm going to say. NSAIDs are huge. Nephrotoxic agents like your aminoglycosides, your NSAIDs, and your contrast materials kill this kidney, okay? Those are common things that cause renal failure, okay? Renal failure. And what it leads to is something called acute tubular necrosis, okay? And when you get acute tubular necrosis, what happens is you get some patchy destruction of the actual renal tubule. And I have a little picture here. So you get some patchy destruction of the renal tubule. Just gotta watch for that drill. Maybe we'll see it. Maybe we won't, right? Okay. So when you look at, come here. Doing this upside down is really hard. Okay. So this is your renal tubule. Okay. So this is your renal tubule right here. What's going to happen with acute tubular necrosis is this lining of this tubule is going to slough off, and then look what happens. Look what happens. So those NSAIDs, that contrast material, those kinds of things, when it causes problems within the kidney, it leads to this acute tubular necrosis. So the renal tubules get affected, and then this lining sloughs off, and then look what it does. It blocks blood flow. So hence now we have kidney problems, okay? You see that? So that's within the renal tubule itself. Okay, so what it is just called, it leads to acute tubular necrosis, and all acute tubular necrosis is problems within the kidney itself. Okay, so you get necrosis and sloughing of the cells that line the tubules. Okay, and then what happens is that it blocks those renal tubules, and it causes increased pressure within the renal system, leading to kidney failure. Okay. So that's renal failure, okay? Renal failure. So the NSAIDs, the aminoglycosides, contrast materials, lupus, those kinds of things can all lead to renal failure, okay? Post-renal is after the kidney, okay? So post-renal means after the kidney. So it results from obstruction to the flow of urine, right? So I can't get the urine out because I have a stone, or I have, a tumor, or I have a stricture, I have BPH. So there are things like that that lead to post-renal failure. So it's past the kidney, except you will see, as I said, renal calculi. I don't know why, but they call that post-renal. So it's obstruction of the flow of urine, okay? So something is causing obstruction to the flow of urine. It can occur at any point within this system. So it can be a stone in the ureter, it can be a ureteral stricture, it can be a urethral stricture. But benign prostatic hypertrophy is the most common precipitating factor. Okay, I'm not saying it's all, but it's the most common precipitating factor. So renal stones, renal tubules, or renal tumors, things like that. Foley catheter obstructions, okay? Foley catheter obstructions can lead to it too. So you really need to watch your patients, but post-renal causes are less than 5% of all the causes of renal failure that's out there. So you really don't see much with post-renal renal failure. So the obstructions can be in the ureter, the bladder, or the urethra, okay? Anywhere in those three areas is where you're gonna see your post-renal renal failure, okay? All right, so this is just diagrammatic. Number one obviously is pre-renal. Number two is in the kidneys itself. Number three is the ureters, the bladder, and the urethra. So that's just kind of a pictorial representation of what's going on, okay? Okay, so far? Pretty much review, right? Well, for some, right? All right, your book talks about this, rifle criteria. I have the new book. And so on the new book, it's on page 1071. I don't want you to memorize that whole chart, but remember, things that are in tables in your book are usually important information, okay? So basically, this is used to describe what stage of renal failure your patient is in, or kidney injury your patient is in, okay? They're looking at the serum creatinine level, okay? So one of the things they're looking at is the serum creatinine level or the GFR, right? And when you see the GFR, they want the GFR greater than 60, and that's the minimum, okay? That's the minimum GFR. But when you look at lab reports, it just says it's greater than 60, but that's a good thing. But that's the minimum that we want a GFR at. So it's going to look at your serum creatinine or your glomerular filtration rate, and the other thing it looks at is your urine output. Okay, so those are the things that they look at in relationship to where do I put this patient? Is this patient at risk for? Okay, does the patient have injury, failure, loss, or are they in end-stage renal disease? So for instance, your book says risk is a serum creatinine 1.5 or a GFR that's decreased by 25%. Okay. And a urine output that's less than 0.5 milliliters per kilogram per hour for 6 hours. So it gives you parameters. And then when you go down farther, it talks about failure as being a serum creatinine greater than 4, okay? And it talks about a urine output very low, or you haven't had any urine output for 12 hours. So don't memorize it, just understand that the purpose of this is to look at, okay, where are they at in this stage? And I always look at their GFR, don't I? When I'm in clinical with the students that I have, I'm always looking at their GFR. So we'll look at the creatinine, but then I always go to the GFR. And what's your GFR doing? We've had GFRs of 15. So where do you think they are in this stage? At the bottom, correct? So all it does is look at the serum creatinine or GFR and the urine output, okay? And it has this table to kind of tell you this is where this patient is at. So that's really all you need to understand, okay? Is that. So don't, try to memorize it because you can't memorize it, okay? It's
For your GFR,
Mm-hmm.
they stop, I always see it where it stops at 60. If it's above 60, we don't
That's good.
typically
yeah, they don't go any farther than that. It usually just says greater than 60. But the average is actually, they like it higher, like 85 to 120. But I don't know that. When they say greater than 60, that's how they just do it. So it's okay. So that's the way they do it. Don't ask me why, but that's how they look at your GFRs.
How do you know if you get a 25% drop then? You just give that generic number.
That's what my question was. So if it was less, so if you had a 50% drop
In what?
then for injury, so your GFR would possibly be
30.
50.
Could be 50, could be 30.
Because okay.
Sure. I always use 60 as my baseline.
Right.
I use 60 as my baseline. If it drops to 30, I have 50% drop.
So if you're saying for this, where GFR normally look at it at 100%, if it's 100%, 75% drop would be you're getting 35%.
Correct.
Okay.
Correct. And you know what? That I give that to the urologists. I
Right.
give that to the renal people. What I look at my GFR. Yeah, Dr. Ramos, okay, show up, because they can do further kinds of testing to figure that out.
Right.
Okay, so they can break that down, but they don't need to. They look at the creatinine, they look at the BUN, and they look at the GFR, and they know exactly where this patient is at. Okay, you just need to understand that those are factors that they look at. Okay, we don't really look at them like they do. We just know, yeah, this patient has some really bad renal issues, and I know that because here's what's happening to my patient, and this is what we're doing about it. Okay, so people will do that. All right, phases. So let's look at this little guy right here, this little patient. What phase of acute renal failure was your guy in your case study? What did people choose? Can't hear you. Allegoric, okay, allegoric phase, okay? So this is less than 400 millimeters or 400 mLs a day, okay? And again, it occurs within 1 to 7 days of kidney injury. Now your book says it a little bit different, but it usually occurs within 1 to 7 days of injury to the kidney, okay? And so the concern that I have with that is what? What kind of concerns do I have? This is what the allegoric phase is. My kidney has been insulted. Okay, my kidney's been insulted. That's what the allegoric phase is all about. Okay, I have minimal urine output. And why do I have minimal urine output? Perfusion issues, okay? Perfusion issues. So what's my urine gonna look like? Dark. Yeah, Coca-Cola color or brown. And why is that? What's increased? If you look at a UA, what's increased? My what? My specific gravity, right? So what does a high specific gravity mean? It's very concentrated, because what's the kidneys not able to do? Filter. So things are spilling out, right? Because the kidneys say, hey, I've been insulted. Help, I'm in trouble. So that's what the kidneys are saying. Help, I'm in trouble. I've been insulted. I need you to do something, okay? So that's what you think about with the allegoric phase. So you have decreased urine output, okay? And so the kidneys are not able to concentrate urine, okay? Hence, we start seeing some changes going on in the patient. So they do not respond to fluid challenges. So that's one of the things that they will do. is they will do a fluid challenge. Now, what's a fluid challenge all about?
500 cc bolus.
Okay,
Given over.
an hour maybe. Okay. So some books say 250, but it's a bolus of 250 to 500 mLs of an isotonic solution given over usually 1 hour. Okay, so that's a fluid challenge. So what you're trying to do is wake up or tickle that kidney to say, hey, wake up, let's start working again. Okay. Sometimes they do not respond to fluid challenges. Okay. All right. So what we want to try to do is give them a fluid bolus to try to figure out where is this patient at. Okay. So they will try a fluid challenge, but the oliguric phase, they will not respond to fluid challenges. Okay. Now, fluid volume overload, right? We already talked about patho, correct? So the kidneys aren't working, so we're not excreting, correct? We're not excreting fluids and we're not excreting electrolytes. So now you need to assess your patient for volume overload. All right? So it's not just, okay, they don't have any urine output. Now what else do I need to look at in my patient for volume overload? Does that make sense? Right. Metabolic acidosis, correct? I can't synthesize bicarbonate, right? And I can't get rid of hydrogen ions. So I get into a metabolic acidosis state. Sodium balance, right? That's a huge problem, correct? Because what's going to happen is the kidneys aren't able to conserve sodium. And so we start having some problems with our sodium levels, okay? Does that make sense? Okay. So then when we look at leukocytosis, why would I even put leukocytosis on here? Why would I even care about leukocytosis? Okay. It's often present with acute kidney injury, number one. It's the most common cause of death in acute kidney injury patients is infection, okay? And leukocytosis, they find, is not due to just one factor. But when you have kidney problems, you still have some inflammatory response going on. And they even think that the stress of the disease process predisposes the patient to leukocytosis. So they don't have an exact cause. Again, it's poorly understood. But leukocytosis is very common, and people in this oliguric phase or with acute kidney injury tend to end up with either a urinary tract type of infection or a respiratory type of infection. And so then what it does is it depletes your white blood cells. Okay. Neurological changes happen. Why? Okay, sodium and what else is building up in my body? Toxins, waste products, okay? So neurological changes occur as those nitrogenous waste products accumulate in the brain and other nervous tissue, okay? Now, the symptoms of the patient may be very mild. They may just say, oh, I'm really fatigued, or they have difficulty concentrating, or it can lead to more things like seizures and comas, okay? So when those waste products get too high, you need to be careful, okay? And they can get that asterixis like we saw with liver disease, okay, where they get those flapping tremors. So they can get that with neurological changes, okay? Increased risk for heart failure makes sense, right? Because what do we have? Volume what? We have volume overload, okay? We have volume overload, hence, if the heart doesn't work, fluid backs up to the body and or to the lungs, correct? Abnormal labs, right? Because the kidney isn't excreting all the ones that are elevated. The calcium is low because my phosphorus is high, okay? Because my phosphorus is high. So what you need to do with these patients is you need to monitor for life-threatening problems when they're in the oliguric phase, okay? You need to monitor for life-threatening electrolyte imbalances and things related to the retention of nitrogenous waste products, okay? So this person was in the oliguric phase, correct? So what assessments do you need to make then? What assessments do you need to make? Start at the top and work your way down. I always say head to toe, head to toe, head to toe, then you don't miss anything. Okay, neurological, what did I just say? It could be as basic as, hey, I'm really fatigued to the point I have difficulty concentrating. Maybe I'm confused, maybe I have a seizure, right? So neurological changes you need to assess for in somebody in the oliguric phase. What else would you assess for in the oliguric phase? Okay, signs and symptoms of fluid volume overload. So you could have right-sided, right, heart issues, or you could have left-sided heart issues. So jugular venous distension, right? Big belly, edema, crackles, okay? All right? So respiratory issues, and I'm not getting into check O2 sat and all that stuff, because that's just when I say respiratory, it's a given, you already know that, okay? All right, what else? EKG, huge EKG, because the biggest culprit right now is the potassium. I want to watch that EKG, and I want to look for any kind of change in my rhythm, and I want to look for those peaked T waves, which you see with hyperkalemia, okay? So I want to monitor that EKG, all right? I also want to listen to their heart, make sure their pulse, check their pulse to make sure it's still regular, because if it's not regular and it was, what's that telling you? They're having EKG changes, and you need to go look, okay? You need to go look and see what kind of EKG changes that they're having, okay? And what else did you put down? Urine output, weight, right? Urine output, weight, okay? Those are some of the physical assessment things that you need to do. And then you have your labs that you need to check, right? Okay, and what's the most dangerous lab we worry about? Okay, the potassium, correct? We already talked about the potassium being really high and the problems that happen with an elevated potassium level. So what are you going to think the physician would anticipate being done for this patient with this elevated potassium level? Okay, insulin, which facilitates the transport of the potassium back into the cell. Okay, D50 does the same thing. How many have pushed D50?
Through 22.
Last week.
I couldn't have done it. My hand would have shook. D50 is really thick.
Did it twice.
I don't know how you got it through that 22. Because it is so thick, you just want to hold the syringe and put your foot up to the plunger and push, because I couldn't do it through a 22. I have arthritis here, but it wouldn't matter. I don't have the hand strength to push it. It is thick, thick, thick like mud, okay? And so it is tough to push, isn't it? Those that have pushed it, it's extremely tough to push it, okay? And what's D50 going to do?
Make sure you don't bottom out.
Absolutely. So D50, make sure you don't bottom out, because we're giving them all this insulin, okay? And what's the other thing I said we give? Calcium gluconate, right? Because the heart is irritable from this high potassium level, so the calcium gluconate is to try to tell the heart to calm down. Okay, calm down, it's okay. So it's cardioprotective for these patients, okay? What else could we give them? K-exolate, right? So K-exolate, right, because that'll help them remove, how do they remove the potassium with K-exolate? Stool, okay? So they remove it with the stool. So K-exolate is something that the physician could do. And what else would he probably have to do if those don't work? Some kind of dialysis, okay? So then we have to think about a dialysis port if they don't have one. So where can you put a dialysis port? Where's a common place? Okay, jugular, subclavian, femoral, okay? So those are the most common ports that they use that are temporary. Those are temporary ports. They are not permanent, right? Permanents are your AV fistula, which is joining an artery and a vein, right? And an AV graft is a synthetic material that just loops around and connects the vein and the artery, okay? So it takes time, bless you, for those, that fistula, especially, because that's the most common one is the fistula. It can take up to 8 weeks for that to mature to be able to use it. Hence, we need a temporary port until we get to that point. okay? So what are you as the nurse anticipating here? What are you going to do for this patient, RN? Okay, maybe a Foley catheter. Okay, we're going to do assessments. Now, what would be my concern about a Foley, though? Infection, okay? So we're trying not to put Foleys in if we don't have to, but I will tell you, if they're in the unit, they will have a Foley and they will be on hourly output, okay? Right, or if the patient's incontinent and we really have to know what this urine output is, then we would put it in. Because remember, we don't put Foleys in as a,
That's easier for me.
right, it's easier for me for our convenience. That's not why we put Foleys in patients, right? Because we predispose them to infection, okay? So we're going to monitor their intake and output, right? We're going to do a head-to-toe assessment. We're going to make sure they're on tally. What else did you put down? Daily weights, good one. Daily weights. Yep, look at nutrition. Maybe the doctor needs to order a consult for the dietitian, right? And then you need to collaborate with that dietitian and make sure they're getting this lovely renal diet, okay? Because they're going to limit their sodium intake and things like that. So, good. Dietary needs, good. Okay, anything else you can think of?
Is this where we do the fluid change?
Yeah, this is where the doctor would probably order the fluid challenge, absolutely. Absolutely, absolutely. This is where the fluid challenge would come in.
Would getting up and walking help?
Actually, when you look at the literature, they say initially bed rest actually will facilitate diuresis because when you're laying down, everything goes to your kidneys. But it's only initially. Where are you coming at with walking?
Because it helps like the blood flow to kind of help perfuse.
Yeah, no, depending on the cause, okay? Because if I have a low blood volume, it isn't gonna matter because my volume is still low. But I like your thinking. I like how you're thinking. That's what you need to do, okay? Seriously. What else did you come up with, anything? Okay, cough and deep breathe, because think about it. You're laying there. I may have crackles, so I may want an incentive spirometer, right? I may want to cough. And do you see what I'm saying? So it's not just always focused on renal. Now, here's the problems that can happen because of the acute kidney injury. So what other things am I going to do for this patient? Does that make sense? So it's not always just related to that, okay? All right. So the next phase that we talk about is the diuretic phase, okay? And the diuretic phase, the problem is my neurons still aren't functioning as well as they should, okay? So the body is trying to compensate, okay? The body tries to pee as much as it can, all right? So the body is trying to pee as much as it can and push the fluid through, okay? So it's saying, okay, I got to get rid of this fluid. I'm peeing as much as I can, okay? And trying to get rid of all this volume. Now, they can diurese a whole lot, okay? They can diurese a whole lot in this stage. So again, as I said, the nephrons are still not fully functional, okay? And so the kidneys have recovered their ability to excrete waste products, but they're still struggling with concentrating the urine because the nephrons are not still fully functional, okay? So we can excrete waste products, but we're still not able to work on concentrating that urine because the nephrons still aren't really functional. So these are things that you can have happen, right? I'm losing a lot of volume. So do you agree that all those things can happen in this stage? So now you got to look for all of this stuff. Okay, so now when you're assessing your patient, you have to think about other things, okay? So the main problem in this stage is volume loss, okay? Is volume loss and electrolyte loss. So fluid and electrolyte issues are common in this stage because 5 liters is a lot of volume, okay? That's a lot of volume. So now you need to be concerned with your patient. I don't go on, I don't test you on how many weeks and stuff because it's ridiculous, but that can last up to 3 weeks, okay, 1 to 3 weeks. But again, everybody's different, all right? So this is where, okay, the insult isn't as bad. The kidneys are saying, I gotta pee a whole lot to try to help you out now because you have too much stuff in here that doesn't belong in here, but the nephrons say, I'm not quite ready to help you yet, right? I still have problems going on. So based on your scenario here, what should be happening with this person around day 3? What do you think you wanna see start happening? What do you wanna see start happening? I want to have some increase in urine output, right? I want to try to have a little bit of increase in my urine output, okay?
Say that, so in the diuretic phase you want an increase in urine?
No, I'm talking about your little guy here.
Oh, okay.
I'm back to this, I'm sorry. So I'm back to this little guy. Based on the scenario and blah, 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 what you want to see happening, while I hope with everything the doctor is doing, right, that I'm starting to increase my urine output. Maybe it's only 600 cc's, right? But that's enough to get rid of the waste products, correct? So that's what I'm hoping happens, is that they're able to increase their urine output at some point in time, okay? Last phase is the recovery phase, okay? And this is where the kidneys are recovering. We're starting to produce urine again, okay? And remember, we need 30 mLs as a base minimum. Now, am I going to panic if it's at 29? No. But if it's at 29, then it goes to 28, and then it's consistently going down, or it's at 25 and it's consistently at 25, then I'm going to worry about it, okay? That's why if you do hourly output, if it's 29 1 hour and 36 the next hour, are you going to worry about it? No. So you have to put in perspective the total amount of volume that you want out and what you're doing and what's going on with the patient. Now, in the recovery phase, it doesn't mean that the kidneys are perfect and brand new again, because they're not. It can take up to a year for these kidneys to really get back to normal, okay? So it just means the kidneys are compensating, okay? And our GFR is getting better. So now that's a good thing. So the serum BUN and creatinine may take up to a year to normalize. So you always may have a little bit of renal insufficiency, meaning your creatinine baseline may always be 1.4 now, okay? So it's not necessarily going to be perfect, okay? Now, the evidence-based practice does state that these patients, once they go through an acute kidney injury, can have up to a 3% permanent loss in their GFR function. So they have lost that GFR, okay? Just aware of that, all right? Okay, so here's some of the assessments, and we've already talked a lot about assessment with the patient with acute kidney injury. So your oliguria and your anuria are your renal, right? Those are things you see renal. Cardiac, right, would be your tachycardia and your EKG changes. You should say tall peaked T waves, but those are your cardiac changes. Your shortness of breath, your orthopnea and rales are respiratory related, right? And these are just some of them. The nausea, vomiting, and anorexia are GI. Why would those even happen? Why would I have nausea, vomit? I stuck flank pain in there too with GI. Why are those even happening? Okay, and take it a little farther. What did you say?
Ischemia?
Yeah, take it farther than ischemia. So if I have ischemia, what's not happening? Not just anemia, what's not happening?
Peristalls?
Guys, it's right there. We talked about it already. Buildup of waste products. Systemic, right? When you have the flu, what happens when you have the flu? What makes you sick? It's the toxins that are released from the virus and bacteria that make you sick. Same thing here. I have all these waste products building up in my body, so I get nauseated, you vomit, right? You don't feel like eating, okay? The lethargy down to the confusion are the neuros, and then the edema and the weight gain are some generalized signs and symptoms. So you do need to worry about anemia as a problem in these patients. You do need to worry about fluid volume overload. So you have to worry about cardiac arrhythmias. You do have to worry about pulmonary edema and things like that in these patients, okay? All right, lab tests. Most of these lab tests you've probably already heard about, except for a couple. And as I already said, there is no other pathological, we're going to get buzzed in a minute. There's no other pathological disease other than renal disease that causes an increase in your serum creatinine level, okay? None other. You may see the term CIN, and if you see the term CIN, and I don't know if you'll see that on boards or not, that's contrast-induced nephropathy, okay? So if you see CIN, just know that that means contrast-induced nephropathy, okay? All right. GFR, BUN, creatinines, electrolytes. Okay, so let's look at the serum cystatin C. Has anybody ever heard of that? Okay, this is something new that's, I guess it's not new, but it's new in the literature. This is actually a protein that's produced by the cells in your body. Okay, you don't need to know more about it than that. But the bottom line is when your kidneys aren't working, that level is abnormal in your blood. Okay, so they will look at the higher the level, the more likely that you're having problems with your kidneys. I've only seen it drawn twice. I haven't seen it drawn very many times, but it's just a protein that's produced by the cells in your body. And when the kidneys aren't working right, they can't keep that level just right. So when it rises, it's saying, hey, your kidneys aren't working. The beauty of this is that level is not affected by age. It's not affected by diet. It's not affected by muscle mass. So that's why they sometimes will draw that, okay? Because other factors really don't affect it. Like your BUN, other things affect it. Like protein affects it and your volume affects it, things like that, okay? Now what about albumin?
A lot of fluid was in there.
Okay, so the kidneys, yeah, a lot of fluid, but the other thing is that the kidneys aren't metabolizing it, right? Because they're not working, so where's the protein going? What are we doing with the protein? It goes out in your urine, right? The kidneys have to work harder and we're losing protein, so hence our albumin levels will be down, okay? Hemoglobin, hematocrit, you understand those, right? Urinalysis, ABGs, correct? What are we looking for with ABGs? All right, we're looking for acidosis. So renal ultrasound is a non-invasive, right, procedure. They're just kind of looking at, is there anything going on in that kidney? All right, is there a tumor? Is there a stone? Is there an obstruction somewhere? And that's basically what a CT and an MRI does too. So they always start with the least invasive, and if they look at it and say, you'll see the report say, well, you know, we suggest or recommend that you do an MRI or recommend that you follow up with a CT. Renal angiography is looking at what? Blood vessels, okay? Renal biopsy, you understand, and abdominal x-ray basically is just looking at like kidney size and things like that, okay? So that's all those are looking at, all right? So medical management, this is just conceptual. I'm not going to read this slide, but these are basically the primary goals of treatment so that we can work with this patient, okay? And the goal is to let's help this patient get better, okay? So I am going to stop here. Okay, so collaborative management, as I said, I'm not going to read through this, but this is what we're trying to do. These are our goals for somebody that has acute kidney injury, and this is patients, okay? So some of the medical interventions that we're going to look at are here. And first, what we have to do before we do any of this is we have to determine if there is adequate intravascular volume and cardiac output to ensure perfusion to those kidneys, right? So if I don't have enough volume and I don't have the cardiac output, am I going to perfuse my kidneys? No. So that's the first step that we have to do, is we have to determine if there is adequate intravascular volume and cardiac output to ensure perfusion to those kidneys. So that's step one, okay? We already talked about a fluid challenge, right? And so 250 to 500, some books say up to 1,000 mLs. over a 1 hour period of time. And the end result of that fluid bolus or that fluid challenge is that patient should respond pretty quickly after the initial bolus. So if I'm giving this person 500 in an hour or 1,000 in an hour, I shouldn't have to wait 12 hours to see urine being produced. Okay, urine should be starting to be produced very quickly. Okay, diuretics. What do we know about diuretics? Okay, so basically, when you're in oliguric renal failure, you usually do not respond to diuretics. Okay, so many times what you will find is they will actually stop the diuretics. Okay. Why this patient is in this phase, because if I'm going to give something and it's not going to work. Okay, so that's why they try the fluid challenges and they try some other things. So the overall effect, though, of what we're trying to do with the fluid challenges is to get urine output. All right, that's what I'm trying to do: tickle that kidney, stimulate that kidney to produce urine. That's my overall goal. Okay, electrolyte replacement. Okay. Again, you're going to have to draw labs, correct, to be able to look at electrolyte replacement and try to decide what do I need to give this patient or what do I need to do. And we already talked about the elevated potassium, correct? And what do we give them? Okay, we give them regular insulin, okay? And we can give them K-oxalate, okay? Okay, calcium gluconate to protect the heart, right? I said that was cardioprotective. That protects the heart from that ill effect of that elevated potassium level. So we look at calcium gluconate. The other thing that they'll look at when we get a little bit farther down, but since I'm talking about potassium, is they're going to limit the amount of potassium the patient can have. All right. And I think it's like 40 milligrams or something like, or 40 milliequivalents a day or something. It's not a whole lot of potassium. Okay. Another thing they're going to do is a medication called low-dose dopamine, okay? Dopamine or ionotropin, what that is that vasodilates in low doses, okay? So dopamine in low-dose dopamine is given to enhance renal perfusion because it vasodilates, okay? Low-dose dopamine vasodilates, okay, the blood vessels, and that way it increases renal perfusion. Okay, so that's what we try to use. So it dilates those renal arteries. So low dose dopamine is for renal. When you get to moderate, like maybe 5 mics per kilo per minute to 7, 8 mics per kilo per minute, it's for cardiac. But low dose is for renal perfusion. Okay, so we're dilating those arteries to get more blood flow to the kidneys. So we may do multiple ones of these at one time. Do you understand what I'm saying? They may be on dopamine plus, we're doing fluid challenges or whatever. But these are just some of the things that they're going to actually do. Okay, epigen. We know what epigen is for, correct? Red blood cell formation. Phosphate binders. All right. So like Renagel. Right, Amphigel, Foslo, right? We've heard of those, correct? Okay, so basically they're used to decrease the high phosphate levels because high phosphate levels, can cause hypocalcemia, and they also lead to the renal osteodystrophy that you see, or the bone issues that they have, more so with chronic than acute renal failure, but that is the problem. So these drugs, they bind with phosphate in the GI tract, your phosphate binders. So they grab onto that phosphate in the GI tract and you excrete it in the feces. Okay, so that's what phosphate binders are all about. However, the problem with phosphate binders is what's a common side effect? Constipation. Good. Constipation is a common side effect, hence stool softeners. Okay. So that is another problem with your phosphate binders. Regular insulin we talked about. Sodium bicarbonate. Sodium bicarbonate also helps shift potassium back into the cells because it's correcting acidosis. Okay, so it corrects acidosis and helps to shift potassium back into the cells. All right. You understand fluid restrictions, correct? okay? Diet restrictions, basically because the kidneys can't work well, we have to limit dietary protein because the kidneys have to work harder, all right? And the kidneys are tired and we don't want them to have to work harder because they're already not working, okay? And so what they tend to do is give them a higher carbohydrates composition in their diet, because if I take in carbohydrates, then I spare my protein, right? So carbohydrates have a protein sparing effect, all right? You have to really teach them about foods that are high in potassium, and you have to teach them about foods that are high in phosphorus. So coffee, right? Coffee, okay, now it's all within reason, right? So I know people who drink 3 pots of coffee a day. Well, that would not be allowed, okay? So 1 cup is probably your limit. So coffee, bananas, fruit juices, potatoes, yes, potatoes. Those things you have to think about. So you have to get dietary involved because they're going to have to do some teaching related to that. Now the limitations are usually in the oliguric phase, right? Because they're not urinating, they have fluid and electrolyte imbalances, etc. After the diuretic phase, then the patient usually gets back on a normal diet after the diuretic phase. Okay, we can increase their protein again when they get out of the oliguric phase. Because the oliguric phase, the kidneys aren't working. The diuretic phase, okay, boom, and then now we go to where? The recovery phase, so we can give them some of their protein back in the recovery phase. Now, do understand that they're going to monitor labs on these patients. They're not just going to say, okay, you can go home now. They're going to monitor labs and say, okay, in 3 months, I want you to have a BUN and GFR done again, or I want you to have your CBC electrolytes, BUN, do you see what and then every so often, they will do that, and then they just gradually change the length of time based on the lab results for the patient. So they're going to do some trending and follow up on those labs, okay? I did find a med when I was studying that I had not heard about, and now I got a little hole, so I don't know the other name for it. It's called Veltessa, VELTESSA. And this was a new drug that was used for an elevated potassium level. So Veltessa, VELTESSA, it's used for elevated potassium level. It's given orally. It's given PO, and it binds with potassium in the GI tract, okay? It's mainly used for chronic kidney disease. It's not used for life-threatening elevated potassiums, all right? So this is used for people that may have, you know, I'm talking, this isn't going to be used for a potassium 8, 9, 10, something like that. So it's used more in chronic kidney disease, but I thought it was interesting. I didn't know that med even existed. So it's not to be used for life-threatening elevated potassiums, but if the potassium levels are consistently a little bit high and they want to keep it down, this is a medication that they can give. So something new out there, okay? Always something new, right? Okay. Continuous renal replacement therapy. When I'm talking about clinical continuous renal replacement therapy, this is basically a means of removing the toxins and fluids from the body. It's a means of normalizing my acid-base balance, right? It's a means of normalizing my electrolytes, correct? In a patient who is what we call hemodynamically unstable because all of these things are going on. So it provides a means to get rid of the waste products and the toxins, right? And just think about the kidney. I have acid-base problems, so it's going to help with my acid base. It's going to help with my electrolytes, right? Because I have electrolyte abnormalities when I have renal issues, correct? And so basically what it's going to do is it's going to help normalize that in the patient until we can get, permanent port and whatever. People that are on dialysis are usually on dialysis with chronic renal failure for life. With acute renal failure, it can progress to chronic renal failure. So this is something that we need to think about and talk about. We already mentioned the access. Okay, I don't even have subclavian in there, and that's the first one I talk about. But vascular access is jugular. Vascular access is femoral. or vascular access is subclavian. Thank you. Couldn't think of that. Okay, so I'm not going through all of this again because we've already assessed this patient. We had a slide on some of the things that you're actually going to see in a patient with acute kidney injury. Okay. All right, so here's some of the things that we talked about. We didn't talk about all of them. We talked about some of these this morning. One of the things we really need to do is manage fluid balance. And we need to be very cautious when you manage fluid balance because we want to make sure that we don't volume overload, correct? If they're already having a problem with volume overload, but then we want to make sure they have enough volume to try to keep that kidney perfused. Because if we're not perfusing, we're not going to work, correct? Okay. So you know about weighing the patient, intake and output, right? That all sound pretty good, all right? If they start having some respiratory problems, positioning and ambulation will help the patient because it helps prevent the complications of immobility like atelectasis or pneumonia, which these people can have. Because think about it, if they're volume overloaded and they have fluid in their lungs and that fluid sits in there, they're prone to infection, right? They're prone to pneumonia. So you have to sit there and think about, all right, I have this renal failure patient, but now what do I have to think about respiratory-wise so this patient doesn't get pneumonia, right? The coughing, the deep breathing, the incentive spirometer, the getting them up, the moving them, right? Good respiratory assessment. Looking at labs, looking at chest x-rays, seeing what all that is and looking at their temperature, right? Fever, things like that, okay? Dietary consult, we already talked about. And then you have the teaching related to actually what's going on, okay? Now, when I talk about acute kidney injury, one of the things you have to understand is that what the physicians try to address is they try to address first whatever's going to kill you the fastest. Bottom line, okay? So if it's that elevated potassium, that's what they deal with. And if it's all this fluid volume overload and you're having respiratory issues, that's what they're going to deal with. Okay, so they want to try to deal with whatever's going to kill you first in relationship to trying to get you on the road to recovery if there's such a thing, right? Okay, all right. So I want to give you back. Okay, so dialysis review. I just kind of wanted to do the Family Feud just for something fun versus, always doing this because, this is not always fun. But anyway, this content will be on the exam because you can have dialysis with acute renal failure, hence we're going to do a review. So dialysis, remember, what they do is it's a machine, and I don't know if I have the dialyzer again, but what it does is that, yes, I do, and some of you have seen this. This is actually the main meat of dialysis right here, okay? And this is, I don't know how to hook everything up because that's why they have people that do that. But if you look in here, and this is getting a little old because these are turning yellow, there are millions of these little straws in here. And basically what this is where all the exchange, this is the semi-permeable membrane. So this pulls all the stuff out, right? Starts pulling the fluid out, the electrolytes out and everything, and then the volume goes back to the body and it keeps circulating for as long as they need to do the dialysis. It's usually 4 to 6 hours, okay? The amount of volume they take off or water they take off is either determined by the nephrologist and or the dialysis nurse, okay? So they have to figure out how much weight they take off. Hence, that's why two of the most important things you need to do pre and post dialysis is what is their blood pressure and what is their weight, okay? I don't care what their labs are, because why? They're gonna fix it anyway, right? So I'm not worried about the labs. What I'm worried about is when they come back, did I take off too much fluid? And now my patient's a little dizzy and dehydrated and have muscle cramps because I took too much off, and then they have to be careful how fast they take it off, okay? Because that can lead to like muscle cramps and things like that. So this is the dialyzer, okay, that they use. And like I said, I'm not a dialysis nurse where I know how everything gets hooked up and and whatever. The other thing is they have these different needle sizes, okay? I don't remember what size this one is, but, you know, I can pass one around, but these are not sterile, so don't poke yourself. But, you know, this is pretty big bevel, okay? This is a pretty big bevel, and that is what they use to cannulate the fistulas on these patients, all right? This one looks even bigger. So here's another one. But I want you to be really careful if you want to look at them, because I don't want you poking yourselves. I'm trying to get all, oh, there's a sucker in there. That's old, don't eat it. That's been in there since this bag was developed, so we don't want that. So that's about the same size.
Paula, what determines if a med's gonna get dialyzed out or not?
I'm gonna talk about that in a second. I'm gonna talk about meds being dialyzed out. Okay, these are all about the same. So if you want to look at them, fine. If not, just pass them on. But please do not poke yourself, because they are not sterile. Okay, we're going to talk about meds in just a second. Okay. So anyway, basically, you know what hemodialysis is all about, right? So this is your semi-permeable membrane that's going around, just like your peritoneal cavity is a semi-permeable membrane, and so that's why they can do peritoneal dialysis. And so what we're trying to do is take care of all this stuff, all right? Fluid and electrolytes, we're trying to maintain fluid and electrolyte balance, correct? We're trying to get rid of all those toxic waste products, etc., that we have in the patient, okay? Now remember, the one thing that I do want to tell you, if you have a patient and they have a brand new temporary subclavian port, you need to monitor this patient, okay? Because what can happen when they put in a subclavian? What am I using to get under the skin? How do I get through the skin? Large bore needle, what's there? What's underneath? My lungs. So what can I end up with? Pneumothorax, okay? So you can get a pneumothorax, and so you need to be... make sure they do a chest x-ray, okay? Post-insertion of a subclavian port for hemodialysis, okay? They usually use a double or triple lumen catheter when they do this, so that they have multiple ports, because you can give meds while the patient is in dialysis, but you can't give them until the last hour, okay? Because the last hour we're done dialyzing, okay? So they're just kind of stabilizing things within that last hour. So if you have to, now sure, you can give a pain med, right? I mean, you can give a pain med, but, you know, the extent of that pain med, you know, it's going to be obviously dialyzed out. I don't know how rapidly that will happen, but you can do pain med, okay? So there was also in the literature here too, just so you know, it says, the reason you can't give meds is because when you dialyze them out, then they're not effective, because it takes them down to their subtherapeutic levels, so they're not going to be effective. So why give them, right? And then antihypertensives and nitrates cannot be given prior to dialysis. And why wouldn't we give nitrates and antihypertensives prior to dialysis? What happens when I pull volume out? All right, so what are these going to do? It's exactly, it may potentiate, right? It may potentiate or exacerbate the, thank you, the hypotension, okay? So it may make it worse. So antihypertensives are a no, nitrates are a definite no, okay? But here's what I say, all right? If it's given daily, do I have to give it at 9 o'clock just because it's profiled for 9 o'clock? Absolutely not, okay? Now, if you're not sure, because maybe it's a Keppra or something for seizures, okay, you may say to the doctor, is it okay that I give this medication? Because you don't want them to have seizures. Or if they're not going down for dialysis for 2 hours, you can probably give the med, right? But you don't want to give any med right before dialysis, because it's going to be dialyzed out. But definitely no antihypertensive, definitely no nitrates, because it will exacerbate the hypertension or the hypotension, okay? So there's a ton of there's a list of drugs that you can give that stay in the system longer and some that don't. But beta blockers, aspirin, Tylenol, ACE inhibitors, all that stuff gets dialyzed out. Okay, so all you have to do is say, hold it, patient in dialysis, right? Now, I would never give a blood pressure medication immediately when a patient comes back from dialysis unless their blood pressure is really high, right? Because dialysis should be removing this volume and lowering that blood pressure, okay? And it's as I always tell my group in clinical, if they have 3 or 4 meds that affect blood pressure, do you have to give them all at the same time? If you're at that borderline 110, 106 mark, I sure wouldn't be giving all 4 of them at the same time. I would look at my patient and say, what else is going on with my patient? So here's my 4 meds that I have to give. Do any of these have any effects on whatever else is going on with them? Do you understand what I'm saying? That might be the med I give them first. So that's what I mean with the thinking that you want to do, because you don't want to bottom them out. I've seen it happen, all right? And then we don't have a whole lot to do for them on the floor, but fluids, and I just came back from dialysis getting rid of the fluids, okay? And you don't want to send them to the unit and have them be put on a level-fed drip, right? So you have to be very, very careful with that, okay? So when you think about dialysis, think about that, okay? We already talked about all of that function stuff, all right? So we already did that. We already talked about that. All right, the frequency of treatments are ordered by the doctors, right? But most of them, it's 3 times a week, and it's anywhere from 3 to 4 hours, 3 to 6 hours, depending on what's going on, okay? When we talk about dialysis. So it's ordered by the physicians, and in some cases, remember, it's temporary, and in some cases, they have to have dialysis for the rest of their life. So you do know that, right? You do need to make sure you teach them that skipping treatments can be very dangerous, because we've had some of our students have had patients who have refused going to dialysis. All right, but then you need to explain that, you also have heart failure, and, this dialysis gets rid of all that extra fluid, and that extra fluid makes your heart have to work harder. And if your heart works harder, it likes to do some things it shouldn't be doing that can affect your health and life. And then you need to go document patient refused dialysis, discussed, blah, blah, blah. So anytime you do anything, you need to cover yourself, okay? So when they first go to dialysis, what happens is they weigh them, and that helps them to try to figure out how much volume they want to take off. So how much fluid do I need to take off of this patient? Because that's one of the things we want to do, right? Is to remove the volume. So that's one of the things that they're going to do. Next, believe it or not, they assess this patient. All right? So believe it or not, they actually assess the patient. They don't just bring them down there, hook them up, and say, okay, we're giving you dialysis. Because what do they need to do? They need to document whether this dialysis worked too, don't they? So they need to have that documentation. So what are they going to be assessing? They're going to listen to their lungs and their heart, right? They're going to look for edema, those kinds of things. They ask them, how have you been feeling? Have you had any nausea? Have you had any vomiting? Any fevers, any chills? And then they get vital signs, and then they hook them up to the machine. Okay, so when they go down there, they are not just hooking them up to a machine and doing whatever. They are assessing these patients at the same time when they're down there, okay? So basically, remember, we already talked about reasons people would need dialysis, okay? And so metabolic acidosis, right? Fluid and electrolyte problems, fluid overloads, those kinds of things, all right? I do not need dialysis for a potassium of 5.4, right? No, because don't you have patients on the floor that have potassium? So don't get that potassium thing out of your head, all right? Or anything like on the test, I had a potassium of 3.3. So what? I didn't have anything that said this patient was symptomatic. So are you going to call the doctor on that? No. What are you going to do? You're going to go first and check, make sure your patient's okay. Secondly, I'm going to see, do they have anything for a low potassium? Right? Or are they on anything that would lower their potassium even more? And then I'm going to hold it and wait till the doctor comes around if they're on a diuretic, right? And say, okay, Dr. Smith, bloody blast potassium is 3.3. They're on Lasix 40 twice a day. What would you like me to do? Okay? But it's not critical that you call them on a 3.3. A 3.3 is not abnormal, okay? Just because it's not exactly a 3.5 doesn't mean you have to act upon it. So that's something, that's part of that nursing judgment that you have to start learning. When do I call? When don't I call? When can I wait? Okay, kind of thing. So you need to start learning some of that. So these are a lot of the reasons you need dialysis: to remove waste products, food and electrolyte balance, bless you, acid base imbalance. Maybe they're hypertensive. You know, those are some of the things that we do for dialysis. You know, it can be done inpatient, right? Or they can have it done outpatient basis. There you go. Those are the kinds of things that we do dialysis for. Okay. So these dialysis patients, once they get to dialysis, all right, they put them on a blood pressure monitor, and they monitor their blood pressure at least every 30 minutes. So their blood pressures are monitored during the treatment, because if they start to become hypotensive, they got to change whatever they're doing, okay? If the patient becomes unstable, they can monitor them and check their vitals every 5 minutes. So if the patient becomes unstable, they can take them as often as every 5 minutes, okay? When we're looking at vital signs and stuff on these patients, okay? So the patients are very, very closely monitored for any kind of drop in their blood pressure. They're monitored for lightheadedness. They're monitored for dizziness, shortness of breath, any kind of symptoms that they're having. So here's some of the common side effects, right? This one was on your little game right there, okay? So they're going to monitor them for some of these complications, okay? Muscle cramps usually happen because we're moving fluid and sodium way too rapidly, and electrolytes way too rapidly. So sometimes they maybe have to slow down how fast they're dialyzing things out, okay? Nausea, of course, you know, again, it's related to the toxins, and again, removing the volume, same as dizziness, right? Dizziness is removing the volume. And then when you talk about headaches, headaches are again due to change in volume and change in the electrolytes. So those are all kinds of common side effects that you can see, okay? But we do very closely monitor these patients. Complications, right? Why do I even have hepatitis on there? Needles?
Yeah.
Okay? I mean, sometimes, you know, sometimes, you never know. So you got to worry about the potential that these patients can get hepatitis, okay? Now, there are some medications that they can actually give through dialysis, and Venifer, which is iron, makes sense. If they have to, they can give that during dialysis. I'm trying to think of the other ones. I asked a dialysis nurse. Vancomycin, Epigen, those are the, I mean, she said there's more, but those were some she said that actually during dialysis they can give. So they can give iron, and they can give like Vanco, and they can give like Epigen, you know, etc. And she said, so I asked her because I wrote this down. So why do they give these medicines? They can give them in dialysis because, you know, the patient's chronically anemic, hence the Epigen. The Venifer is given to help the red blood cell mature, all right? And Vanco they give as prophylaxis for infection during the whole procedure, okay? But she did give me another one. It was called Zemplar, Zemplar. That's actually activated vitamin D. So Zemplar, I'd not heard of it, is actually activated vitamin D. And so you know why we give that. So anyway, these were just some of the medications that she said that they actually do give during dialysis, okay? The medications, remember, can dialyze out, even the Vanco. And so what she said was they usually only give them during the last hour of treatment, because very little bit of the medication is lost during that last hour, because that's where the least of the dialysis or the dialyzing is occurring.
Would you worry about hypoglycemia? Could you pull all that off?
Hypoglycemia.
Yeah, like in the diabetic. Because like when I donate plasma, I get hypoglycemia. And then pulling all that off for me.
But it's going right back in them. Right, but they're also their volume is going back. They're getting everything back.
Same to me.
Yeah, I don't know. I don't
Or
either.
is it just me that?
That might be
happens
you.
to?
I don't know. It might be you. I don't know. I've not heard of anybody becoming hypoglycemic.
I thought it's a similar process to donating.
Yeah, I've never heard of anybody becoming hypoglycemic. You could look it up for us. That'd be nice. You got your phone. You got your phone. Look it up. So anyway, process of dialysis. I'm not going to go through all of this because I am not a dialysis nurse. But again, you know, you hook the patient up, right? And then they can set a pressure here, which I don't care. But see, they have to put heparin in so that this system doesn't clot, all right? And then the blood is cleaned out here and then it's returned back to the body, okay? Hemodialysis is great because hemodialysis is a much more rapid process than peritoneal dialysis, okay? Peritoneal dialysis takes a lot longer, okay? And so one of the advantages is the removal of all these urea, potassium, all that stuff, creatinine, and you can get rid of fluids a lot quicker than with peritoneal dialysis. So peritoneal dialysis isn't very fast. The problem is with hemodialysis, you can have vascular access problems, right? Even if it's subclavian or whatever, so that's an issue. You need a lot of equipment, hence what you see here. You need a lot of equipment. The personnel have to be trained to do it, right? So you have to train people to actually do the hemodialysis. Another disadvantage is surgical placement, right? They have to have surgery to either place the temporary port or the fistula, okay? Self-image problems, if you've ever seen an AV fistula, right? Okay. And the other problem that they really have is the really huge drop in blood pressure if we're not careful with how much we take out, okay? So blood can be given during dialysis, but it can only be given in the acute care setting. So like the dialysis places or whatever you call them, you know, where you go outside of the hospital, they're not allowed to give blood, okay? And what the dialysis nurse said is that, you know, obviously it makes sense. She said blood pressure meds should be discussed with the nephrologist and or dialysis nurse, okay? So if you question a med, call the dialysis nurse, okay? And say, hey, I got this patient, what do you think? I mean, they're experts because that's what they do. All right, do you think I should do this? Should I not do this? Because if the patient's blood pressure gets too low, she said that it affects this process and they might not be able to get enough volume off the patient because we have the low pressures. And we need pressures within the system to be able to pull that volume off, okay? So, obviously, here's the AV fistula, right? And this is the synthetic graft, okay? So, fistula and graft, correct? Okay? So, the fistula is the artery in the vein, right? Takes 4 to 8 weeks to mature. Before we can use it, you know, the bruit and the thrill are really critical for you as the nurse from an assessment standpoint. And the biggest problems are thrombus and infection, okay? And then the graft, the problem with the graft, it's just a bridge between the arterial and venous, and see how they have to sew it. So you have to give it time to mature and heal. And it takes up to 4 weeks for that to be able to heal. And the problem is you still can get infections, you still can get blood clots. This can get plugged a lot easier, okay? Because this actually, if you actually saw a real one, it's really big, okay? But this can get blocked a lot easier. And so that's something that we have to worry about, okay? Now, the National Kidney Foundation, from an evidence-based standpoint, says they recommend, now this is more, I think, for outpatient, but recommends at least a weekly inspection and palpation for a pulse and thrill at the arterial and venous access. They want you to look for warmth. They want you to look for swelling. So what that means, what they're trying to say is if you have patients that are out there in the real world and they're going home and they're going to be on dialysis, you need to at least teach them how to palpate, right, for a thrill, if nothing else, okay? Because they're not going to know how to do a bruit because they won't have the equipment to do it, okay? I will tell you the fistula, according to the dialysis people, is the gold standard, okay? That is the gold standard for dialysis because it's their own artery and their own vein. So we have less problems, okay? So that is the gold standard. They can get better blood flow with the fistula than they can get with the graft. So that's why they call it the gold standard. Okay. Again, the biggest problem is it just takes so long for the fistulas to mature before we can actually use them. And, whatever. The AV grafts, they don't last as long as the fistulas do. And I think that she said they only last maybe 3 to 5 years max, a synthetic graft like at the bottom. So, that's not very long, right? When you think about having to get picked and whatever. Now, this is something that is out there new in the literature. This is called a hero graft. And this is scripted, so I can show this. Do you have this? Okay. Designed for patients who have narrowing of large vessels. Now, I hate to do this because I don't know what'll happen here. So this is something new that I found when I was researching, and it probably might not load. Maybe it will. Let's see what happens. To your attention. So this is just showing you again long-term catheter. Okay, this is tunneled. Okay, like the med ports are tunneled underneath the skin, and that's why this is good. So this part of the vein isn't any good, so they bypass that part of the vein and they use that as a port for dialysis, basically, is what they do. Okay. Caring for the AV fistula and graft, you already know about that, correct? So you want to make sure that repeated compression can cause you to lose that graft, and we don't want that to happen. And so you need to be very cautious, and you can look those over, and they're in your book too. So, okay. Pre-dialysis care is your patient assessment, right? What do I need to assess in my patient pre-dialysis, okay? So weight and blood pressure, huge, right? Those are the two pre and post that you really need to think about. And then you always need to check the site, right, for a bruit and a thrill. And if you don't have one, you better be calling the nephrologist, right, and saying, hey, I don't palpate, okay, a thrill, and I'm not getting a bruit, because then we're going to have to do something else if this patient really needs dialysis, okay? Medicines to be held, we talked about antihypertensives. I questioned mark cardiac meds because it depends what they are. Like, I wouldn't be giving beta blockers to this patient. I wouldn't be giving nitrates to this patient. But when in doubt, just call the dialysis nurse, okay? But antihypertensives and nitrates are the two you surely do not want to give to this patient prior to dialysis, okay? So they're all hooked up. Now what? Well, there's the meds right on there. There you go. That's what I was telling you earlier, okay? Medications such as Epigen, Zemplar, which is the vitamin D, and the Hectorel is activated vitamin D also. They can give those. So that was what I was telling you earlier. These are some things that they can give during dialysis. They will still dialyze out at some point, but these are meds that they give during dialysis. Okay, you have that slide, right? All right, narcotics dialyze out, blood pressure meds, again, you've got to be very careful, because if it's too low, then we cannot get enough volume off of these patients. You have to be very careful, because if the patient is unstable, you really need to monitor these patients, okay? Because if they're having chest pain or they're having arrhythmias, you need to not send them, right? Because something's going on. So you have to really monitor them. If their blood pressure is unusually high or unusually low, you need to contact the nephrologist, okay, and or the dialysis nurse, and ask them what they want you to do, because blood pressure medications or how much volume they want to take off may have to be adjusted. So you've got to be really careful with these patients, because they can go down really fast. All right. You always need to monitor for fever in these patients, right? before and after. And you need to let the dialysis nurse know if they have a fever, because if they have a fever, that can impact them going to dialysis. So any signs of infection, you need to notify the dialysis nurse, and I would also notify the nephrologist, of course. But if they're going down to dialysis today, I have to let the dialysis nurse know too, okay? You got to remember when they come back to let them rest, because dialysis is like running a marathon for your heart, okay? So you need to allow them to rest when they come back. The machine does to their body what it normally would take a couple days to do. That's a lot of, you think, oh, dialysis is nothing, but it's really a lot of trauma and stress on the body. And so, you know, you need to let them rest when they come back from dialysis, okay? So those are just some of the things related to dialysis. Post-dialysis care, of course, you know, vital signs and weight, and you need to compare them to pre-dialysis. Since they have had some heparin in the system, you need to also think about no invasive procedures, okay? Unless you absolutely have to, because they can bleed, okay? Temperature may be a little bit elevated post-dialysis, and it says right there why, because these patients are getting, the volume is being warmed, okay? They warm it up and then put it back in the patient. And so you may find that they have a slight temperature when they first come back from dialysis, okay? Or does that kind of remember hemo now? Okay. Peritoneal, I don't have a lot on peritoneal because a lot of it is the same. When you go back to this, the automated peritoneal dialysis is the most popular because this is done when the patient is sleeping, okay? So this is done when the patient is sleeping. And then what they do is in the morning when they get up, they unhook themselves from the machine, right? And then they leave that fluid in the belly or in the peritoneal cavity for the day. And then when they come back at night, they connect themselves up and let it come out, okay? Then the process starts all over. When they go to bed, they hang a bag, okay? They leave it, it goes in overnight, they leave it sit during the day, take it out. So then they can still go about and do their activities, all right? So anyway, that's the automated. The continuous ambulatory, this is done 7 days a week, 24 hours a day, okay? And basically, the dwell time is usually 4 to 8 hours, okay? But these people are a little sicker, and so they need to do this a little more often. And so basically, again, what they do with this is that a lot of patients will just take the bag, all right, and you know, they let it go in, and then you know, they can keep the bag connected if they want. They roll it up and put it under their clothing. So sometimes they do that, but the continuous ambulatory is 24 hours a day, 7 days a week. So there's always something going in, something coming out. Okay, so that's kind of a little bit more, I don't know, I don't want to use the word difficult, but a lot more to it, okay? How do I know which one to use? I don't know. That's up to the doctors. So I have to look at their cardiovascular status, and I have to look at what's going to happen when they go home. You know, is there going to be somebody there that can help them, or is there not anybody there that can help them? With peritoneal dialysis, they can add heparin to this. They can add potassium. They can add antibiotics. They can do whatever they want to do, okay, depending on the doctor. And this is a good video if you want to look at that video, okay. Care of the patient, basically the same thing, right, as for your hemodialysis patient, except what's different? The abdominal girth, right? Right? Because I'm putting volume in my peritoneal cavity. So I want to know what's going on. So I worry about abdominal girth a little bit more, okay? Because I want to make sure it's coming out, right? I don't want stuff getting stuck in there. So if I'm putting it in, I want it to come out. So that's the main difference in the two, okay? Again, these are all in your book. Those were what we just saw on the slide, except for protein loss, because what do I want to call it? The peritoneal membrane is permeable to plasma proteins. So proteins can go across the peritoneal membrane and be dialyzed out. So that's one of the other differences that we have when we talk about peritoneal dialysis, okay? You understand the rest of them? Peritonitis, right? Rock hard abdomen, belly pain, right? Because sometimes that fluid sits in there and they can get an infection. I already mentioned the exit site infection, so where they put the catheter in, the dialysis catheter can get an infection. Hernias, low back problems are due to all that volume in the peritoneal cavity. Outflow problems, right? So check for kinks in the tubing, maybe position yourself a little bit differently, all right? Makes sense? Respiratory problems. All right, the last little thing, and I don't really say much about this, so a lot about this in the test, but kidney transplants, right? What's my choice? Dialysis or a kidney transplant? There is a ton of criteria for a kidney transplant, and we're not even going to go into what that is because it's not up to us to figure out, okay? So you can do a live donor. That has the highest rate of graft survival. So that has less rejection with a live donor. 90% of, according to the literature anyway, 90% of live donors are usually a relative, okay? Are usually a relative. A deceased donor, if they've just died and they can donate, sometimes that happens. But these things have to be compatible. The human leukocyte antigen is a genetic marker that is on the WBCs. So we all have this human leukocyte antigen, or HLA, and it's on the WBCs. And the closer they match, the less chance of rejection. So this is something that they look for when they're looking for donors. Okay, obviously blood type, because you have to have the same blood type, right? Or you're going to have problems. The human leukocyte antigen, that's that marker on the WBC, and that we want it to match as closely as possible so there's less chance of rejection, okay? And then we have to look at antibodies, okay? Because they may produce antibodies against some of the donor tissues. And so sometimes they'll take a small sample of the donor's blood and the recipient's blood, and they mix them together to see if they're going to have a reaction prior to the procedure, okay? So see if there's a problem, okay? Somebody, basically it's everything, you know, I really need to look at my urine, and I'm looking at this stuff because I want to make sure my kidney is working, right? So if they're having pulmonary edema and heart failure, that's telling me maybe my kidney's not working, right? Because I shouldn't have that. The whole purpose of that new kidney is to take care of all of that. So you monitor weights, labs, right? Your BUNs, your creatinines, right? Your GFRs, your hemoglobin, hematocrit, electrolytes, those kinds of things, okay? Immunosuppressants, why do I have to give them immunosuppressants? Rejection, okay? And it is very important that you teach these family members and the patients that they need to take those rejection meds for the rest of their life, okay? They cannot take them. So here's some of the signs of rejection. The decrease in urine output, the BP, right? Okay, elevated creatinine, etc. If it's going to occur right away, it usually occurs within the first 48 hours post-surgery, okay? But it's not limited to that period of time, okay? The patient will have an increased temperature and decreased urine and all these things that you see right there. So monitor for an increase in serum creatinine too, all right? Because that should not be going up, all right? Infection can be a complication, not just because of the surgery, but they're on immunosuppressant medication, right? And immunosuppressants suppress your immune system, hence greater chance for infection. So now you've got to teach the patient, right? Avoid crowds, avoid my class because they sneeze and cough, right? Can't come in here, right? Avoid crowds, good hand washing, right? Stay away from people that are sick, all those kinds of things, okay? Acute tubular necrosis can be an issue because what are we manipulating when we're doing this? The kidney itself, aren't we? So acute tubular necrosis can be due to, number one, ischemic damage because we have to transport the kidney, right? So there's a certain length of time that they have to get the organ from one place to another and get it inside and get blood flow, okay? And also due to the manipulation of the kidney. So we can actually get acute tubular necrosis, okay? Somebody asked me about this, and again, I'm not going to test you on this because I don't know a whole lot about it, but this is something new that is out there. This is an artificial kidney, and it is done for people that have end-stage renal disease, okay? Now, you may see it on boards. That's why I'm giving it to you, okay? So boards can test you on about anything. What it is a very small dialysis machine. I know this looks massive. That's just worn on the outside. The machine itself is worn on the outside of the body. And basically, it's connected to the patient via like a little catheter. Okay, so they have a little catheter, and it provides around-the-clock dialysis. And I don't remember, is it run on, I think it's batteries. I think it's run on batteries. And the battery, I don't know how long the battery life is, but I just thought this was interesting to show you that there is something new. So this is just comparing. Now this is the same as this. Now what would you like? Right, but that's why I showed you this. I don't know a lot about it. I mean, I just, I really haven't researched it that much, but I just want you to understand that that is out there. And obviously they have to have a catheter of some sort into blood flow for this to be able to dialyze out. But I mean, I just think I just look at this stuff and think where we've come, related to technology, etc. Okay? All right, so you should do good on dialysis for me, right? Is that how your brain feels? Your brain